So our next keynote speaker, Dr. Jenn Simmons, is a breast cancer integrative oncologist. She's also a surgeon, author, podcaster, and founder of Perception Imaging. She is a pioneering force in the world of breast cancer care and author of The Smart Woman's Guide to Breast Cancer. So if you haven't seen her table out in the hallway, please go see her after with my breast cancer ladies in the audience. Joining us all the way from Philadelphia, my sister in pink, Dr. Jenn Simmons.
Yeah, so I am always on brand. You will rarely see me in anything with pink. Much to my children's dismay, they're like, "Oh, Mom, enough with the pink. Does everything have to be pink?" And in my world, everything does have to be pink because I am very much born into this breast cancer world. I did not choose it. It definitely chose me. And as Tracy said before, I am deeply connected to God and my religion. And I know that God put me here with great purpose to change the conversation around breast cancer. And though I'm going to be talking primarily around breast cancer today, I want you all to know that the things that I talk about, these principles apply across the board. Because as several people have said, this isn't about killing anything. And cancer is not a foreign invader. It's a part of you. And it's the part of you that is trying to signal you, to message you, to tell you that something needs to change. And while I am a doctor, I am not your doctor. So please know that what I'm talking about here today are general principles and what I truly believe. And there is science around all of it. But there is no one thing. There's no one procedure. There's no one pill. There's no one drug. There's no one food. There's no one supplement. There's no one treatment. There's no one anything. Because we are all bio-individual. And what is going to work for you and what worked for me may not work for you, and everything in between. And I'm here on this stage, not as a surgeon, because that is where my career started, but as someone who became a patient and realized that our system is broken and it is so tunneled and siloed that we don't see the landscape, and we certainly don't see the person in front of us. And so as I went through my personal journey and my personal healing, I gained perspective that is invaluable. And though we're never grateful for our disease, we are grateful for the opportunity that it affords us. And for me, it was the opportunity to heal millions and millions of people that I would have never had as a surgeon. So what I'm talking about today is what I call the forgotten woman. And though we are talking about my first book, The Smart Woman's Guide to Breast Cancer, this is the title to my next book, which will be out next year. And just to let you know, I am going to talk about my imaging centers, and I am owner and operator of these imaging centers. Sorry, trying to do two things at once. And we do have some learning objectives today that I want to make you all aware of, because I hope that we walk away today with understanding in these areas that maybe you didn't have before, because I tend to talk about things that are fairly provocative and fairly controversial, and I think extremely important for people to understand. So I want to talk about the way that we screen for breast cancer, the way that we treat breast cancer, and understand the current treatments and the long-term implications that these treatments have. I want you to understand the unappreciated consequences of breast cancer treatment and why they're so important. And we're going to review the data and the argument around HRT, both before and after breast cancer, and understand how we as practitioners can safely and compassionately care for women with a history of cancer while minimizing their risk for cancer recurrences. So what we're going to talk today about mostly is what I call the quiet after the storm. So someone gets diagnosed with cancer, and life gets very noisy and very busy. And you go to doctor's appointment after doctor's appointment after doctor's appointment, and you go from one treatment to the next, and you're really put on this treadmill very quickly. And there's a lot of rushing, a lot of decision making. You don't have time to think. You're often not given the tools to think, and you're so stressed. You're in that cortisol dominant state where even if you did have the time and the space to think, the facts aren't there and available to you, and you are so scared that you just agree to what you're told to do, and you have a very busy month, 2 months, 3 months, 6 months, a year, whatever it is. And then you finish treatment. You finish this conventional treatment paradigm, and all of a sudden, everything gets really quiet, and you're kind of left to your own devices, and, what do I do now? And I call this the quiet after the storm, and for many people, this is the most terrifying part, because they don't know what to do. They don't know what's next. They don't know how to help themselves. And in that conventional medical model, they're almost robbing you of your power, because you're so conditioned to think that the solution comes from outside, and you're not given any indication that the solution actually lies in you. And so we finish treatment, and we're told you should be grateful to be alive. And you are. You are grateful. Of course you're grateful. But it's very hard to feel grateful when you can't sleep, you can't think, you can't remember names or words, you have brain fog, anxiety, depression, you're afraid, you lack confidence, you've gained weight, you have gas, bloating, heartburn, you feel and look deformed, you have palpitations, you feel weak and tired, you have dry skin, dry hair, dry nails, dry everything, you have no libido, frequent urinary tract infections or yeast infections, you're leaking urine, you have no libido, sex is unwanted and painful. It's hard to feel grateful when all of this is happening. And yet, this is how we leave most women after breast cancer treatment. Now, you'll recognize the side effects of breast cancer treatment in all of those things that I just talked about. Fatigue, diarrhea, lymphedema, breathing problems, loss of appetite, taste changes, cognitive dysfunction, skin changes, hair loss, which is sometimes permanent, premature menopause, poor immunity, neuropathy, heart problems, osteoporosis, breast deformity, low libido, depression, hot flashes, sleep disturbance, mood disturbance, joint and muscle pain. It's hard to feel grateful on the other side of this, and yet this is how we are leaving most people in the conventional medical model. When they've been through treatment, this is what they're through treatment with. And we're not talking about small numbers. When we just look at breast cancer alone, we're talking about 1 in 8 women over their lifetime, and actually, now, because of what we talked about yesterday, the jab, we're talking about more than 1 in 8 women. And so with these numbers, it is nearly impossible to not be affected by cancer. Because if it's not you, it's your sister or your mother or your daughter or your neighbor or your teacher or your colleague. It's nearly impossible to be untouched by this. And when we look at the number of new breast cancers every year, this number just continues to rise. Now, I do want to call out something in this slide before we move on, because one of the factors that we blame breast cancer for is hormone replacement. And for many, many years, we were told, patients and doctors alike, that hormone replacement is one of the major causes of breast cancer. So I don't know if you guys are aware of the Women's Health Initiative, the biggest study on hormone replacement that was ever done. It was a $1 billion study. And the study was halted in 2003 after 5 years because it concluded prematurely and incorrectly that hormone replacement was associated with an increased risk of breast cancer. And almost overnight in 2003, 80% of the women taking hormone replacement went off their hormone replacement, and only a fraction remained on, and that is still true today. And yet, when we look at breast cancer incidence, if we start this graph at 2003, we just see a steady increase in the incidence of breast cancer. And I will say to you with great certainty that it is not the hormone replacement. But there is an etiology that we need to talk about today. So just to give you absolute numbers, in 2022, we had 287,850 new cases of invasive breast cancer. In 2023, 790,000 cases. And in 2024, we diagnosed 310,000 women with invasive breast cancer. And those numbers just continue to rise. But what hasn't risen is deaths from breast cancer. And thank God that we don't have more deaths from breast cancer. But if survival is increasing, and we're not having more deaths, but we're having more and more diagnoses, is it because we're getting better at treating breast cancer? Because the truth is, our treatments haven't changed. In many, many years, our treatments haven't changed. So I have to ask the question, what's happening? What's happening? Is it just becoming more of a survivable disease? And the truth is that that's not it. There are currently more than 4 million breast cancer survivors in the United States today. And we are, without question, creating much of this disease. And we get depictions of breast cancer survivors that look like this, right? Joyous, happy, healthy, vibrant. But as we well know, and by what I started this talk with, surviving breast cancer doesn't look like that. Surviving breast cancer and the way that we are leaving women after breast cancer treatment is with a whole host of side effects that rob them of that vitality. Now, we need to ask, why is there so much breast cancer? And certainly, we know that breast cancer is a metabolic disease, and we have plenty of metabolic dysfunction in our country. We know that less than 10% of Americans have ideal metabolic health. So these are very troubling numbers, and most people don't know where they are from a metabolic standpoint. We know that breast cancer is an environmental disease, that we all have an inherent toxic load that we can tolerate. And once you exceed that toxic load, you start to see dysfunction. The breast is without question the canary in the coal mine. It is extremely vulnerable and extremely sensitive to environmental toxins, and we have plenty. We are not living on our grandmother's earth. We're not even living on our mother's earth. And the earth that we are living on today is exponentially more toxic. But we do have significant data and know that some of those toxins, like sugar, is a toxin, right? So some of these toxins that we are encountering will contribute to metabolic disease and metabolic syndrome. And metabolic syndrome is significant and important in the initiation, the progression, the treatment response, and the prognosis of breast cancer. So the metabolic component is extremely important. And breast cancer is without question an epidemic. Without question. Ooh, I need to go back. One second. But I think that we need to understand from the medical practice standpoint our role in creating some of this disease. Because in actuality, our breast cancer screening is creating a large percentage of breast cancer. And this is a problem. We have been all told that mammograms save lives. This is something that from the time that I went to medical school was drilled into me. I came out of medical school and went into residency, and it was drilled into me. In fellowship, it was drilled into me. And when we train, we pretty much assume that someone has done the work, that someone has done the due diligence, that someone has done the investigation. And if they are teaching it to me, that it is true. And in all the years that I trained, and it was a lot, and in all the years that I practiced surgery, and it was a lot, I never questioned this. And I ordered thousands and thousands and thousands of mammograms, never knowing, never thinking that there would be consequences to that I wouldn't pay for, that someone else would. Now, I want to talk a little bit about our mammographic screening program and how it started out and its inception and its intention. Because like most things, I think that it started off with good intention. And in the 1970s, when our mammographic screening program started, it was built on 3 foundational understandings. So it assumed that breast cancer growth was both linear and predictable, and that finding small tumors would decrease the amount and the severity of treatment, and that mammograms would both save lives and save breasts. It's a lovely theory. It's even a logical theory. It just doesn't happen to be true. So breast cancer growth is neither linear nor predictable. Now, this is different than other cancers. Colon cancer growth is very linear and very predictable. Colon cancers start as a polyp. The polyp degenerates into an invasive tumor, and that invasive tumor then grows in a linear fashion, and when it reaches a certain point, it's more likely to metastasize to the lymph nodes and to the liver. This is very true of colon cancer. This is not true of breast cancer. Breast cancer is all about biology. It is what it is from the very beginning. And you can have tiny cancers that are very aggressive and very apt to metastasize. And you can have big tumors that aren't going anywhere at all. And the bottom line is that anyone can live without a breast, but you can't live without your essential organs. And I am not advocating for mastectomy, and I am not discounting the horrible, horrible devastation that a mastectomy brings, but you don't need a breast to live. And so my point is that we cannot predict based on size what a breast cancer is going to do. However, by screening with mammogram, that is the only thing that mammogram can pick up is size. It doesn't speak about biology. So we know that finding something small is absolutely meaningless in the course of what is going to happen to that woman. And I'm stuck. Oh, there we go. Okay. So we also assumed that finding small tumors would decrease the amount and severity of treatment. But as it turns out, in our conventional medical system, we treat everything the same. So you just get put in a bucket, you get put in a silo. Do you have invasive cancer or do you have non-invasive? If you have invasive cancer, are you hormone positive or hormone negative? Are you HER2 positive and HER2 negative? Once you check those boxes, you just get put in the same exact treatment silo that everyone else who has that same piece of paper that you gets put in. And nowhere are they talking about the biology of your disease. Nowhere are they thinking about the sensitivity of your tumor. Nowhere are they thinking about the person that sits around that breast. And so all treatment becomes standardized. So they're not giving less treatment. Once you check that box, once you get that sign, you have breast cancer, everyone's treated the same. And if mammograms saved lives, though, it would be worthwhile, right? It would be worthwhile if they truly saved lives. But the truth is that no matter how many mammograms we do every year, the exact same number of women die of breast cancer. The exact same number. No matter how many mammograms we do every year, we diagnose the exact same number of women with aggressive disease. And these are the women that are not going to do well, ultimately. Mammogram does not impact the bottom line. And since we started to screen with mammogram, you would think that if we're finding things smaller, people would have less treatment, and less treatment would mean less mastectomies. But as it turns out, mammogram has only increased the mastectomy rate because of fear. Because of fear. Because your doctor doesn't want to spend the hour to talk to you about the fact that mastectomy does not increase survival, that it does not improve outcomes. And I will tell you, having been a surgeon for 25 years now, there is no way to prepare a woman for the devastation of mastectomy. You can never, ever, ever prepare her properly for what that is going to mean afterwards. And the number of women that make this decision out of fear, because I don't want it to come back, or I never want to deal with this again, and the fact that they don't tell you that it doesn't guarantee that in any way, shape, or form. And women are opting for this out of fear. And we have not decreased treatment, and we have not decreased mastectomy by using mammogram for screening. So what have we done? Well, when we look at the studies, come on. It doesn't like me. Point here? Okay. All right, got it. Thanks. When we look at the studies of what mammograms actually do, we learn that they increase mastectomies, they lead to overdiagnosis, they lead to overtreatment, and they do not decrease mortality or death from breast cancer. And so this is a real problem. And I would like to spend a little time, if I can get my screens to advance, talking about the issue of overdiagnosis, because at the end of the day, this is what mammogram has done. Mammogram has increased the diagnosis of breast cancer by 20 to 30%. Now I'm going to give you a little bit of perspective on that. If we diagnose 300,000 women a year in the United States with breast cancer, we're talking about 60 to 90,000 women a year in the United States who didn't need to be diagnosed with breast cancer, didn't need to be treated for breast cancer, and yet they are. And they're living with the consequences of this treatment. So, what is overdiagnosis? Okay, so overdiagnosis is the detection of breast cancers that would have not caused harm in a woman's lifetime. That means that these cancers either grow so slowly or they remain so small and localized that they would have never become symptomatic, they would have never spread beyond the breast or caused death. They would have remained undetected. We're talking about subclinical changes in the breast. And quite frankly, everyone has cancer cells in their body, from the very young to the very old, and everyone in between. And we have an immune system that inherently is supposed to recognize these processes in their infancy and take care of them. And it's happening all day, every day, in everyone. But by using tools like mammogram, which is a very unsophisticated tool, to find these microscopic findings, these microscopic changes, and then biopsying them and giving them a diagnosis, giving them a name, giving them a title, assigning them this meaning, that many of them, 20 to 30%, they would have never reached the threshold of clinical disease. And this is a problem because overdiagnosis is hurting thousands and thousands of women a year. And in the interest of time, I will not go through all the studies, but the two that I point to the most are the Cochrane Review and the Canadian Breast Cancer Screening Trial. And they both had the exact same findings. So the Cochrane Review, 600,000 women, and they were divided into screening with mammogram and physical examination. And when you look at the two groups, they have equal access to care. So none of them are in care deserts, right? They have equal access to care. And the care that they get is exactly the same. And because it's the Swedish trials, because, everyone has the same medicine. And what they found is that the exact same number of women die of breast cancer in both groups. And the only difference between them is that in the group that screens with mammogram, there is a 23% increase in diagnoses of breast cancer, which means that 23% more women in that group had to go through surgery and radiation and had to take drugs like tamoxifen or aromatase inhibitors and live with all of the consequences of taking those drugs, which are not insignificant. And then there's the Canadian Breast Cancer Screening Study. And this is a study done on 90,000 women in Canada. Again, the Canadian trials, they have the exact same access to treatment and the exact same treatment should they get diagnosed. And they find the same exact thing. The women who screen with mammography and the women who just get physical exam, the number of women that die of breast cancer in each study is exactly the same. And the only difference between them is in the women that screen with mammogram, there's a 30% increase in the number of breast cancers diagnosed and a 30% increase in women who go through surgery and radiation and chemotherapy and take tamoxifen and aromatase inhibitors. So overdiagnosis is a huge issue. And when you look at this graph that I have out, this is the comparison of women dying of breast cancer in the group that screens with mammogram and the group that doesn't. Do you see any difference? Is there any benefit here to screening with mammogram? And I think the thing that we ultimately need to talk about is when we screen with mammogram, we are, bottom line, using an X-ray. We're using radiation to screen for cancer. And radiation is a known carcinogen. This isn't my opinion. This isn't me making it up. You can ask any radiologist, does radiation cause cancer? And every single radiologist will say yes. And then you ask them if a mammogram causes cancer, and they say, no. Who told you mammograms cause cancer? We use mammograms to screen for cancer. Yes, I know you do. But we gave it a nice name, right? Mammogram, picture of the breast. But what if we called it what it was? What if we called it a breast X-ray? Don't you think everyone would know what it is? And yet, radiologists all over the world insist that mammograms are safe. In fact, my favorite argument is, well, it's the same amount of radiation as a cross-country flight. Would you really tell people not to go on an airplane? No, of course I don't tell people not to go on an airplane. I took an airplane here myself. But when you're on an airplane, you get exposed to scattered radiation, right? Scattered. When you're getting a mammogram, this is focused radiation, coned down radiation to the compressed tissue of the breast. So the breast is already being traumatized, and then we send focused coned down radiation through the breast. So if anyone remains unconvinced, I just want you to picture this. The sun is probably the greatest collection of energy there is. And yet by the time the rays reach the earth, the worst you get is a sunburn. A laser has a fraction of the energy that the sun has, and yet lasers cut through rock, cuts through glass. It's the same thing. Mammograms are capable of tremendous damage, and they are in fact causing some of these cancers. And as a result of using this technology, we are overdiagnosing cancer, and this is a problem. Because 20 to 30% of women are treated unnecessarily, and I'm not even talking about the women who are diagnosed with DCIS. That's an entirely different conversation of women who are told that they have breast cancer, though that is a completely non-invasive condition. So I think that that's a terrible misnomer. I don't call that cancer. I eliminate that language around those changes and that condition. But yet, those women are subject to this treatment too. And this is a huge problem because when we treat a woman for breast cancer, we increase her risk of heart disease, we increase her risk of neurodegenerative disease, and we increase her risk of osteoporosis. And lest we forget, every single year, the same number of women that die of breast cancer die of a complication of a fracture. Every single year, the number of women that die of breast cancer is eclipsed by the number of women that die of heart disease. And that includes the women who have a breast cancer diagnosis. Because most women who have breast cancer don't die of breast cancer. Most women who have breast cancer die of cardiovascular disease, part and parcel to how we're treating it. So this is a problem. And the risk of cardiovascular disease in women treated for breast cancer is 2 to 3 times the general population. And depending on how you're treated, it can even be higher than that because the treatments of breast cancer are associated with an increased risk of cardiovascular disease and an increased risk of cardiomyopathy. And if you're treated for breast cancer, you are 2 to 3 times more likely to die of cardiovascular disease than your colleagues who are not. And then what about osteoporosis? If you are treated for breast cancer, most of the treatments for breast cancer will decrease your bone health. So the hormonal therapy prescribed for postmenopausal women with breast cancer lowers their estrogen, leading to osteoporosis. Tamoxifen gives postmenopausal women with hormone-positive breast cancer a state of estrogen deficiency, which leads to bone loss. Chemotherapy leads to premature menopause, estrogen deficiency, and bone loss. And radiation has direct impact on bone health, leading to osteoporosis of the ribs, the pelvis, and the spine. And reduced physical activity, which is often associated with breast cancer treatment, increases the risk of bone loss. Oh my God, you're kidding me, 10 minutes? Okay, I really have to speed up. Okay, I'm gonna move on. And beyond all of that, the psychological harms of breast cancer screening are substantial, they're long-lasting, and they affect a huge number of women. And I want to be clear, I am not saying that breast cancer isn't a devastating disease. It is. It is. But we are making it so much worse by the way that we're screening for it and the way that we're treating it. So I think it's clearly time to abandon mammography. And I think that we need to also take a long look at how we're treating breast cancer, who we're treating for breast cancer, and what we're doing to prepare women for the rest of their lives. Because I think that it is absolutely wrong to save a woman from breast cancer and leave her with a life that's not worth living, with a life where you have fatigue and diarrhea and lymphedema and breathing problems and loss of appetite, taste changes, cognitive dysfunction, skin changes, hair loss, premature menopause, poor immunity, neuropathy, heart problems, osteoporosis, breast deformity, low libido, depression, hot flashes, sleep disturbance, mood disturbance, joint and muscle pain. I mean, this is not life. This is not life, and we can do so much better. Now, I am not saying that no one should have traditional cancer treatments. Obviously, if your proverbial sink is overflowing, if you have a significant amount of tumor volume, we need to do things to change that. We need to do something to turn it around. Your sink is overflowing, we have to mop up the floor. We sometimes need all of these things. But the far more important thing, the far more important part is that we need to turn off the faucet. We need to figure out why that breast cancer is there. We need to look for those sources of inflammation in your diet, processed foods, sedentary lifestyle, over-exercise, radiation exposure from repeated mammograms, x-rays, radiation in childhood, chronic diseases like obesity and diabetes, thyroid disease, which affects over 25% of us, celiac, inflammatory bowel disease, MS, chronic infections like viruses and fungus, mold, Lyme, parasites, bacteria, heavy metals in our drinking water, dental amalgams, food, cosmetics, chemical exposures from plastics and phthalates and fungicides and herbicides and preservatives, xenoestrogens, chronic antibiotic use, chronic dental infections, cavitations, frequent toxin exposure, alcohol. We have completely normalized alcohol, and yet it's the biggest modifiable risk factor for breast cancer. Smoking, chronic constipation. This is the last way that we get rid of our estrogen byproducts. If you're not getting rid of them, they're just coming back into your circulation. Insomnia, sleep is where the healing happens. If you're not sleeping, you're not healing. Chronic sleep deprivation, short sleepers, night shift work. As it turns out, you need to sleep with the sun. Being overweight, the electromagnetic field, unresolved trauma. If you have unresolved trauma, it's going to present as a physical symptom. Chronic stress from a difficult relationship, a bad marriage, a horrible boss, being a caregiver to a sick parent, a spouse, a partner, child, a divorce, a job loss, or unwanted move. We need to be thinking about all of these things and all of these causes of breast cancer, because if all we're doing is mopping up the floor, we're not turning off that faucet. And that is the important thing. That's what we all need to be thinking about. I'm just going to move past this, because we talked about what all of these treatments cause and the side effects of all of these treatments. And I want to finish up by talking about, I'm going to get there. Who needs treatment? What treatment everyone needs? And, did I pass it? Maybe. No, I'm good. And so when we think about a treatment plan is what everyone gets, right? Everyone gets a treatment plan. So you're told that you need surgery, or maybe you're getting cryoablation, radiation, chemotherapy, and AI, tamoxifen. These are the conversations that everyone is getting, but the conversations that everyone needs a health plan. And everyone needs to be talking about what diet is right for them, and fasting, and sleep, and movement, and toxin avoidance, and detoxification, and stress management, and having really good stress management tools, and doing mindset work, and off-label drugs, supplementation, environmental optimization, and living a connected, purpose-driven life, because the number one predictor of how long you're here on this earth is how long you want to be here, and what you're doing while you're here. And so living connected to your community with a purpose-driven life is so important. Thinking about all of those causes of breast cancer and how they apply to you. And then I just want to end by talking about the role of hormone replacement, because though we have villainized estrogen for the purposes of selling estrogen blocking drugs, the truth is that estrogen, and I'm using that one term to talk about all of our estrogens, but estrogen is without question the hormone of life. And it is only when we start to lose our estrogen that everything starts to significantly deteriorate. Our brain starts to significantly deteriorate. Our heart starts to significantly deteriorate. Our blood vessels, our bones, our joints, our mood, our sexuality, everything goes away with when we lose our ovarian function and when we lose our estrogen and the other sex hormones. So there are two books that I really recommend. One is Estrogen Matters by Avram Blooming. The other one, Happy Healthy Hormones by Dr. David Rosensweet. So I encourage you to get those books. They're amazing, and they tell this estrogen story in a beautiful way. Just know that we have estrogen and progesterone and testosterone receptors all throughout our body. They're there for great purpose because they really promote our health. And I've asked repeatedly, well, is hormone replacement safe? Does it cause breast cancer? Is it safe before? Is it safe after? And the truth is that all of the data that we have points to the safety of hormone replacement before breast cancer, and all of the data that we have points to the safety of hormone replacement after breast cancer. I personally am talking about bioidentical hormone replacement. I only believe in using the hormones that are inherently produced by our body so that they're recognized by our body as safe, so that our body knows what to do with them. But of the 20 studies that were done in women who have had breast cancer and took hormone replacement afterwards, every single study, with the exception of the IMPACT trial, which was a highly flawed trial and has since been retracted, every study found the exact same thing. There is no increased risk of recurrence, and let's face it, women who take hormone replacement have recurrences, and women who don't take hormone replacement have recurrences. But the women who take hormone replacement and have recurrences have better outcomes, and they have better lives in the translation. So there's no increase of risk of dying of breast cancer with hormone replacement. And there is an increase in longevity, in happiness, in health, in energy, in everything. So I think that we need to completely reconsider how we screen for, how we diagnose, how we treat breast cancer, and more importantly, we need to consider what the life of that woman is going to be like after breast cancer, because we need to leave women with a life worth living. And that means that we should be considering hormone replacement in every single woman after treatment. So just briefly, this is what I do. This is my personal workup where I get a baseline labs and I'm looking at all of these factors. I'm helping people to optimize their metabolic health, optimize their environmental health, optimize their diet, their sleep. We're talking about all those foundational things that Dr. Stroop talked about earlier today. But in addition, like peptides are something that enhances, hormones are something that enhance. There's no magic anything. taking hormones on top of a bad diet or poor sleep routine or sedentary lifestyle is not going to help you. But when you couple it with all of the foundational pieces of wellness, they make all the difference in the world. And they combat all of these side effects that we talked about. And they preserve and maintain bone health, brain health, sexual health, mood health, really everything. Sorry, I'm just going to blow through to the end. And so I'm happy to answer any questions for you guys. I know that my time is up. But I just want to leave you by saying that health is a journey. It's not a destination. And there is no one that can make you healthy other than you. You are the only one. And health does not happen in a doctor's office. It doesn't happen in a hospital, in a medical oncology suite, in a radiology suite. Health happens at home with the things that you do every single day. It's what you do most that matters. And if you build those foundations of health, then hormone replacement can make a huge difference in how you feel, in how you look, in how you sleep, in how you move, in how you everything.
Okay, thank you. Thank you. Thank you. Is this on? Hello? Is this on?
Me neither.
Thank you so much, Dr. Jenn. You're helping so many women like myself with breast cancer. I know we have a few people in the audience. If we don't get to your question today, Jenn has a table out in the hallway, so be sure to see her. And she'll answer all your questions there, and make sure you get her book so she can sign it for you, and we'll be giving some away right after these questions. So, would you like to? I can talk loud.
Hi, Dr. Simmons.
Hi.
It's so nice to meet you. I was blessed to get to use your QT image scan. So if any of you haven't had that done and need to have a screening, highly recommend it. It's a beautiful procedure, such a lovely experience. So in September, I was diagnosed with DCIS. Western medicine wanted to do double mastectomy right away. You mentioned this I've seen you on podcasts and things, mentioned that you don't consider this as a classification as cancer. Do you know what causes the calcifications in the milk ducts? And if we know why they start, is there anything we can do to help prevent them or to stop them from growing?
Yeah, I have an amazing video on YouTube for anyone who is wondering about calcifications. Just Google Dr. Jenn Simmons calcifications. But the truth is that the calcium itself is not the problem, right? The calcium is a chemical process that's happening that's just reflective of those cells dying. So what happens with DCIS as it expands within the duct, because it does not have the capability to grow outside of the duct. That's what makes it different than invasive cancer. So all DCIS is contained within the ductal system. And what happens is the ductal system only has a blood supply outside of it. It doesn't have a blood supply inside. So as these cells start to reproduce and fill the duct, they can't get nourished. And so they just die off. And in that die-off process, they get calcifications. So that's what's happening. And we can tell sometimes when we look at them on a study, if they are linear lining up, we can tell that they're lining the inside of a duct. And that's how we know that that's what it's associated with. But again, I don't consider this cancer because, in my opinion, cancer has to be something that is threatening of your life. DCIS is not threatening of your life. No one ever dies of DCIS, ever, 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 ever. And I think that when you get a diagnosis of DCIS, which incidentally we see calcifications on QT, I don't call them. Because unless there is a mass there, I'm not putting someone through that process. And so it's the same thinking, that slide of where are these changes coming from? What is your body trying to tell you? What do you need that you don't have? What do you have that you don't need? And walk through that process of what's out of balance. So I see DCIS as an opportunity.
Thank you so much.
Mhm.
We don't have a whole lot of time for questions, so please make them very quick, and we'll have to go to this side now. And so short questions, otherwise try and get Jen outside.
Okay, I want to tell you I love your lecture. It was close to my heart. I've been treating cancer patients for 20 years, starting with myself with great success. And what I feel like I could have been in the same lecture at the same time 20 years ago. We haven't advanced. And my biggest issues are, why are we over-treating inductive? Why are we doing double mastectomies for early cancers? You can't scream success. I mean, like you said, they didn't have the cancer, right? And number two,
Must be the money.
I know it's about the money, but when an MDs come into our world, like such as you, and start making changes because we can't make those changes, like, why do we have to have a mammogram? We ultimately get an ultrasound, and then we do MRI. I have to fight for my patient, and mammograms have ruined them.
I hear you.
Ruined them.
So you can like Donald Trump, you can hate Donald Trump, you can like RFK, you can hate RFK. I'm telling you that RFK tapped the shoulder of me and every one of my colleagues who stands for what's right and what's wrong in this medical system. We are changing the world.
Right, and
I promise
I'm
you,
thrilled.
we are
I'm
changing
thrilled
the
about
world.
him being in, because I already see him making major important changes that are going to affect cancer results. But
We're not going to have this conversation in 4 years. Because I'm taking time out of my life and my schedule to go to Washington to say no one should ever get another screening mammogram, ever.
Okay, we have time for one more question. Thank you so much, Jen. That was amazing. We have one more question, and then anyone else who has a question, just please see Jen.
I'll go sit at my table, and you guys can ask me anything you want.
We love you.
Hello, my name is Petra Sovkov. I'm a
Hi.
medical herbal practitioner and doctor of natural medicine from BC, Canada.
Amazing, thank you.
Thank you. I was hoping that maybe you could comment a little bit further on something that was touched on briefly. And I think it's really important potentially for people to hear about this. And that is that when we talk about cancer, whether we're allopathic or on the holistic natural side, we all agree that it's an inflammatory disease, right? So we have, and I see this in my own clinic, is stage 1 or preclinical patients being given mastectomy, double mastectomy, which then creates further inflammatory injury, which then creates the perfect storm for actually cancer to develop beyond these stage 1 or preclinicals.
Yeah.
Would you be comfortable commenting a little bit more on that?
Yeah, and I'll take it a little further.
Thank you.
Even if it's not the physical changes, which no doubt surgery is a trauma, right?
Mm-hmm.
And the bigger the surgery, the more trauma. And, you know, if you're having a mastectomy alone, that's a little less trauma than a mastectomy with a reconstruction. And depending on which reconstruction you choose, you may have 1 procedure, 2 procedures, 3 procedures, 4 procedures. You may have 10 procedures, right? And each one creates more inflammation. But what about the inflammatory change that comes along with losing a breast? Because this is what I used to tell my ladies when they would say, well, what should I do? Should I have a lumpectomy or should I have a mastectomy? And I would tell them that, you know, a well-done lumpectomy, there will come a day where you will no longer be defined by your breast cancer. You may not even remember that you had breast cancer, but I promise you this, if I take off your breast, no matter how beautiful the reconstruction I do, and you know, I was pretty good, but I'm not God, right? And no matter how good the reconstruction is, there will never come a day for the rest of your life that you won't remember that you have breast cancer. And the weight of that is tremendous. And that stays with you. And that is a source of inflammation that women have for the every day for the rest of their life.
Yes, the process of unprocessed trauma and inflammation.
Yes. Yes, exactly. So I agree with you. I don't tell people what to do. I would never tell someone what to do. What I want to do, why I wrote my book, The Smart Woman's Guide to Breast Cancer, I want everyone to have the information that they need in order to make an informed decision, because they are not getting that now.
Correct.
They are railroaded by fear.
Correct. Thank you so much. I appreciate that.